Welcome to Catalyst Medical Review. Today we'll be talking about asthma. First, we will define asthma. Asthma is an airway disease that has both an inflammatory phase and a constrictive phase. The inflammatory phase involves the mast cells, eosinophils, T lymphocytes, neutrophils, and epithelial cells. Together, these cells and the substances they release cause the airway to have an increased response, which is described as airway hyperresponsiveness. As a result of this hyperresponsiveness, there is excessive mucus production, which can decrease airflow and, in some cases, totally block it. The second phase of asthma is the constrictive phase. In this phase, the airways become very narrow and restrict airflow. The sum total of both phases results in excessive mucus, edema, wall thickening, and narrow airways. The epidemiology. Asthma is the most common chronic respiratory disease. It is a worldwide problem. In the Western world, asthma affects 10% of adults and 30% of children. Worldwide, asthma affects approximately 300 million people, and the mortality rate is equally staggering, accounting for over 250,000 deaths yearly. Here's a schematic showing normal airway with normal lumen diameter, and it also shows an asthmatic airway with constriction and wall thickening with edema, and it shows a very constricted airway in severe asthma where the lumen is very constricted and the walls are thickened and edematous. The clinical presentation of asthma. The primary presentation of asthma is wheezing, which is the result of bronchial constriction. Bronchial constriction is usually the acute phase of asthma. This is followed by the inflammatory phase. There is no specific timing between the two phases. Usually, expiratory wheeze is longer than inspiratory wheeze. In addition to wheeze, patients may present with cough, dyspnea, tachypnea, tachycardia, agitation, hypercapnia, hypoxia, accessory muscle use, nasal flaring, chest pain or tightness, decreased pulmonary function, and decreased forced expiratory volume in 1 second, which is described as the FEV1. In terms of the history, getting the history on an asthmatic patient should include the following questions. Number 1, do you have asthma? Number 2, how long have you had symptoms before coming to the ER? Number 3, how frequently do you have episodes? Number 4, how frequently do you use medication to control your asthma? And lastly, have you ever been intubated? The history should also include medical problems that these patients may have, such as we should inquire about COPD, heart failure, previous bouts with pneumonia, seasonal rhinorrhea, or eczema, and particularly in children. Now, the types of exacerbation. Whenever a patient comes to the emergency department for asthma treatment, it is always due to acute exacerbation. However, that acute exacerbation may be mild, moderate, or severe. Let's talk about mild exacerbation. The features of mild exacerbation include, number 1, expiratory wheeze on auscultation. Patient will have dyspnea on exertion. They may experience tachycardia, or there may be mild agitation. Some patients will have intermittent cough. Others will have a feeling of chest tightness. But usually in mild exacerbation, the vitals are within normal range. With moderate exacerbation, and in addition to the features seen in mild exacerbation, patients with moderate exacerbation may have additional findings such as the use of accessory muscles or shortness of breath during the conversation while attempting to give the history, and they definitely will have tachycardia. In terms of severe exacerbation, the features of severe exacerbation include hypoxia, severe agitation, the absence of wheeze, which is very important in an asthmatic patient who seem to be very tight. It means that they're so tight that they're not moving in the air to mount a wheeze on auscultation. Nasal flaring, severe accessory muscle use with signs of exhaustion, hypercapnia with the PCO2 greater than 42, cyanosis, and altered mental status. Caution should be taken. Remember, patients are at greater risk for impending respiratory failure if they are non-compliant with medications, if they have had a previous intubation, and if they have had a long duration of symptoms before coming to the emergency room on the current visit. High alert. Oxygen saturation is a very good predictor of the severity of symptoms on initial presentation. Signs of low oxygen saturation include paradoxical breathing, accessory muscle use, cyanosis, and a respiratory rate greater than 60 breaths per minute. And this particularly should be looked for in the pediatric population. Risk factors for death from asthma. We should consider the history of asthma in these patients. We should consider previous severe exacerbation, which would include intubation or admission to the ICU. We should consider if they have had 2 or more hospitalization for asthma in the past year, or if they have had 3 or more ED visits for asthma in the past year. We should also consider hospitalization or ED visit for asthma in the past month, and if they are using more than 2 canisters of a short-acting beta agonist per month. And also, we should consider difficulty perceiving asthma symptoms or severity of exacerbation. That is, if they have these symptoms and just can't recognize it. That becomes a big problem. The low socioeconomic status in inner city residents is also a major risk factor for the younger population with asthma. If they also are engaged in illicit drug use, if there is any major psychosocial problems, and if there are comorbidities such as cardiovascular disease, concomitant lung disease, or chronic psychiatric disease. All these play a role in increasing the mortality rate in asthmatic patients. The diagnostic studies. The finding of hypercarbia on blood gas analysis is a strong predictor of impending respiratory failure. Metabolic acidosis on blood gas is an indicator of impending arrest. The decision to intubate and mechanically ventilate the asthmatic patient should not be based on blood gas analysis only. Rather, it should be based on the clinical picture of mental status respiratory effort, and air movement. The diagnostic studies. The end tidal monitoring in an acute asthmatic with exacerbation should demonstrate low carbon dioxide levels. If the carbon dioxide is very high after 30 minutes of treatment in the emergency room, that's a bad sign. A peak flow should always be performed prior to treatment if the patients are able to do it. Remember, peak flow is based on the height, age, and sex of the patients. The treatment. Short-acting beta agonists are the cornerstone of asthma therapy in the ED. The most common of these short-acting beta agonists is albuterol. Long-acting beta agonists, such as salmeterol, have no role in the ED. Ipratropium bromide works by blocking the cholinergic stimulation of airway smooth muscles, and terbutaline may also be used. Corticosteroids are a mainstay of therapy in acute asthma exacerbation. They work via two pathways. Number one, there's the reduction in the airway inflammation, and number two, there's an upregulation of beta receptors. Magnesium sulfate is thought to work by inhibiting smooth muscle action potential. IV or subcutaneous epinephrine have been shown to be efficacious for the treatment of asthma. Epinephrine appears to be safe to be used in the elderly with very little risk of ventricular dysrhythmias or other significant adverse events. This should not be considered a first-line therapy. Let's continue with the treatment, but I just want to run by you some dosing. Magnesium may be given in the amount of 2 grams IV over 20 minutes, and that's in adults. In the pediatric group, it may be given from anywhere from 5 to 75 milligrams per kg up to a max of 2 gram IV over 20 minutes. In terms of prednisone, the adult daily dose is 40 milligrams. The pediatric dose is 1 to 2 milligram per kg divided into 2 doses with a maximum dose of 60 milligram per day. Epinephrine, and we should be using 1 in 1,000, which is equivalent to 1 milligram per ml. The adult dose is 0.3 to 0.5 milligram every 20 minutes for 3 doses sub-Q. The pediatric population, you can give 0.01 milligram per kg up to 0.3 to 0.5 milligrams every 20 minutes for 3 doses, also sub-Q. In terms of terbutaline can be given in a dose of 1 milligram per ml or 0.25 milligrams for 3 doses. That's in the adult population. In the pediatric population, it can be given as 0.01 milligram per kg every 20 minutes for 3 doses, then every 2 to 6 hours as needed sub-Q. Ipratropium bromide can be given to the adults as 0.5 milligram per 2.5 ml, or you can give 2.5 ml every 6 hours. In the pediatric population, those who are younger than 12 may be given 1.25 ml every 6 hours, and if they are older than 12, they may be given adult dose. Methylprednisolone and dexamethasone also play an important role in the emergent treatment of asthma. The outpatient classification. In an outpatient setting, asthma may be classified as mild intermittent, which means that there are 2 or fewer attacks per week. Then it may be considered as mild persistent, which means that there are more than 2 attacks weekly but not daily, then it may be classified as moderate persistent, which means there is daily attacks and exacerbation. And lastly, it may be classified as severe persistent, which means that there's frequent exacerbation with physical limitation. So let's summarize this. Remember, the most common cause of wheezing is asthma. However, there are other medical conditions that can cause wheezing, namely CHF, COPD, lung cancer, and cardiomyopathies. So in conclusion, it is important to recognize asthma and initiate treatment very early and be aware of signs of respiratory failure. I do hope that this short presentation has made a difference in your review of asthma and will benefit you in your upcoming examination. Thanks for listening, save lives, and I wish you well.